Well, it's my pleasure to share with us more on frontline therapy. We're going to be evaluating both ineligible and eligible patients for transplant today, of course, and I'm focusing in on patients who are ineligible for transplantation. So, what are my objectives for the talk? We'll review the importance of frontline therapy in myeloma. This is going to be repeated, I know, in multiple talks today, but starting off correctly with our patients becomes critical. We'll talk a little bit about the decision making process when we think about transplant eligibility, and then really focus on the key trials that are now demonstrating that even in this more frail population, that using triplets are preferred in patients not going to transplant. And then at the end, I'm going to share a particularly important study that we've known about for a while, but was just recently published regarding dexamethasone dosing. So, as is mentioned in multiple different ways in myeloma, we know that this is a disease that becomes more aggressive with time. We know this is a disease that has clonal evolution. We know this is a disease that has more and more chemo resistance over time. And all of these things point to the significance and the importance of using our so-called best therapies or most effective therapies earlier on in the treatment course. We don't so-called save the best for last. I always say that's great for a Hallmark movie, but it's not good for multiple myeloma because we really need to get into a deep and a durable response early on, knowing that sadly with time, remissions tend to be shorter in multiple myeloma. So just to kick us off, I won't go through every last detail. You can read this as I'm describing it, but here's a relatively common presentation of multiple myeloma. A 76-year-old Caucasian male, initially complaining of fatigue, has known some osteoarthritis, but not particularly unwell, who it does not look particularly well on exam, but not awfully sick, consistent with the patient's known osteoarthritis, but objectively is anemic, is hypercalcemic, has some degree of renal insufficiency with a creatinine of 1.5, and is therefore sent on to hematology for evaluation. When we evaluate him, indeed, he's got a creatinine clearance of only 50. He's got a significant IgG kappa monoclonal protein of 3.4. He has a kappa predominant light chain profile with a ratio of just under 30. You can see the LDH and the beta 2 microglobulin there, not overly remarkable, an albumin of 3.5. And his marrow demonstrates and confirms myeloma with 43% plasma cells, but specifically no high risk features. In fact, it has hyperdiploidy, which typically gives people a better prognosis. So as you think about a case like this, what are you offering this patient? What are you thinking about in this patient? Would it make a difference to you if I said instead of hyperdiploid, the patient was P53 deleted or high risk disease? In the absence of head-to-head studies for some of these treatments, what is the best treatment for this patient? Is it VRD? Is it DRD? Is it a melphalan-containing regimen? We have more and more options than we've ever had before, although generally speaking, we're approaching these patients with VRD and DRD, and I'll give us updates in both of those realms. And then very significantly, this gentleman is 76, has a little bit of osteoarthritis, but could we still consider him eligible for transplant? What is it that we choose when we think about eligibility? And this is a whole separate topic, and we often discuss this in different areas, which we will in our Great Debates and Updates program. But a couple of things that I like to mention from the ASCO guidelines that I had the privilege of leading a couple of years ago, where we did mention the importance of referring patients for a transplant center to make that assessment, and that assessment should not be made by chronicle age alone. So you should not look at your patient and just say, "Oh, he's 76. Oh, he's 72. Oh, she's 62," and then immediately make a decision about transplant. It really age is only one of several phenomena that we use as we come to determine a patient's eligibility. Well, let me cut to the end of the story and then work back. We really have three major treatment modalities being used worldwide here. And I'm going to suggest the most commonly used ones are the ones that are the first and the last in this slide, with a couple in the middle. We do tend to use VRD light or RVD light. It's really just a modification of the VRD protocol that we see in the SWOG trial. And we tend not to use the Alcian approach or daratumumab plus VMP or bortezomib, melphalan, and prednisone because we've typically in the US not used a melphalan base. But if we look at the two outside pieces that I'm going to give you more information on, we really have some important differences. There's a younger age of patients in the SWOG study versus the MAIA study in general, but we do see quite impressive short-term, and now we're starting to see long-term outcomes. Indeed, where in the Dury SWOG 777 study, we still haven't reached certain features, as you can see here, the overall survival for PFS2, for example. But we do see how patients can do, a response rate over 90% in both of these two major studies. And we'll talk more about these details with time. But I think what's important for us is to know is we now have longer term data for these kinds of studies. So what was this first study? Well, this was the SWOG study comparing giving bortezomib, lenalidomide, dexamethasone versus just lenalidomide, dexamethasone. And then patients had the bortezomib dropped after 8 21-day cycles, or roughly 6 months, and then remained on lenalidomide and dexamethasone in the long term. And what we learned from this study was the primary endpoint of progression-free survival. Now with a median follow-up of over 80 months, we see how those two curves remain apart. We have a 41-month versus 29 months. So to tell a patient off the start with this regimen, 41 months of progression-free survival over 3 years is really quite impressive. And we see this now bearing out in the longer term. But not only for progression-free survival, but indeed for overall survival. You see a hazard ratio here of 0.7 comparing these two arms, where we see quite impressively here that 50% of patients are still alive, in that almost 90-month time frame. So technically not reached here, as you can see, versus 69 months, but it looks like it's in that range of a little over 90 months. So really quite impressive with this. And of course, when we look at age, this does have a bit of an impact. Obviously, patients who are younger, although these patients were not immediately intending to go to transplant, we had younger patients on this study. Obviously, the neurological events become particularly important with bortezomib. I will note, as you can see here, that in this study, the bortezomib was initially given IV and twice a week, as opposed to the standard way we give it now, subcutaneously and weekly. So quite impressive results with VRD. Well, now we've had a recent update of the DRD regimen, or the MAIA study, which had a relatively similar design with daratumumab lendex versus lendex. The major difference being here is that the daratumumab was continued with the RD indefinitely, as opposed to stopping at that 6-month window as we do with the bortezomib, with again the primary endpoint of progression-free survival. And so a little bit more detail here about how the daratumumab, of course, is given, and patients were treated until disease progression or an unacceptable toxicity. Not quite as mature as the VRD, but now with we can see at 48 months, 60% of patients in the DRD arm are still not progressed. So we really have quite an impressive hazard ratio of here of 0.54 in terms of progression-free survival in these patients. When we look at the subgroups, it's quite consistent across the subgroups. We may argue that perhaps the high-risk subgroup may not fare quite as well as a standard risk subgroup, which tends to be highlighted from this slide in the bottom right-hand corner. But generally speaking, we see quite impressive consistency. Furthermore, one of the concerns comes up saying, well, if I'm giving this daratumumab long-term, is this going to impair my ability to treat the patient later? And now, thankfully, with more and more options available to our patients, we find that actually the PFS2 was not impaired. And so we see that the subsequent patient progression-free survival, there was still a benefit in being the DRD arm versus the RD arm. So the authors concluded here that we see an improvement in PFS with DRD over RD, driven by deeper responses, including, although I didn't get time to go into all the details, a tripling of the MRD negativity rate, and that this did not impair longer-term progression-free survival in terms of PFS2, and there were no new safety concerns. We know that there are always safety concerns with these regimens, not my focus of the talk today, just to give us the options, but ones that place it in context to help us understand the value. So this clearly remains, in both of these regimens, VRD and DRD, are clearly available to us from a guideline standpoint and a reimbursement standpoint. But before I leave this, I do want to make a comment, and I think it's important to think a little bit together about dexamethasone. Because, as some of you have heard me say, I joke sometimes that I want to change the name of my myeloma clinic to the Dexamethasone Reduction Service, because we use dexamethasone so emphatically as we did in these studies. But we now have increasing evidence that maybe we shouldn't be using it quite as long as we first thought. I use this picture because I speak to every patient of mine about what I call the booster rockets on the shuttle. And I describe dexamethasone as booster rockets on the shuttle. It seems that almost no matter what we add dex to, it has a potentiating, a beneficial effect. In these cases, whether it's VRD or DRD, we've seen this in multiple other regimens, almost every regimen we have in myeloma. You give dex, it's really helpful, but we all know it's hard to sustain that dex. Typically, I'll give 40 milligrams weekly in younger patients who are typically going towards transplant, and those who I deem transplant ineligible, as we mentioned, not just age alone, but by various methods of frailty, I will start at 20 milligrams weekly. But it doesn't mean I'm indefinitely giving them. I typically say to them, these first 2 to 3 months are really important. But then the boosters have to start coming down, and we begin to taper patients. And this makes a huge difference on their well-being, because we should be asking about the critical symptoms of insomnia, of the psychological effects, and often speak to the patient's spouse about it, hyperglycemia, hypertension. And we know with time it can have other effects in the endocrine system, other effects on bones and the skin, and multiple other areas. So in this study, the idea then was to give patients lenalidomide and dexamethasone continuously on the bottom, but see if there would be a difference in giving lenalidomide and dexamethasone for a defined period of time, in this case, 9 cycles. Sometimes I use even less than this, but at 9 cycles, and then just lenalidomide. And continue until progressive disease or intolerance. Now, what's interesting about this study is, although we're going to capture things like progression-free and overall survival, they wanted to look at their primary endpoint of event-free survival. So this includes progressive disease, all-cause death, but also lenalidomide discontinuation and grade 4 hematological events, as well as non-hematological grade 3, 4 events that included second primary malignancy. So an important design to look and evaluate if there were, if you will, other toxicities from dexamethasone that may not be captured typically in just efficacy measures. Well, when it comes to the efficacy measures, interestingly and importantly, really no difference. Look at the PFS difference here. At 20 months, 43% versus 42%, so not different. Similarly, even for overall survival at 20 months, 84 and 79 months. So really no significant difference between the efficacy of these two regimens. However, and by the way, we saw this really across even depth of response was really not significantly different between the two arms. There is some difference here, but the p-values, as you can see here, are not significantly different between the two. So the real question then would come is, was there a difference in event-free survival? And indeed there was, benefiting stopping the DEX and just continuing lenalidomide. So the RDR versus RD, as you see here, 9.3 months versus 6.6 months, which met statistical significance. So even with the same outcomes, patients that had the DEX dropped had these improved outcomes overall in terms of event-free survival. The improvement of tolerability, as you can see here, that 9% of patients discontinued early and about 4.5% of them for toxicity. So this is really now, I think, validating what we've known in myeloma for a long time, which is that those booster rockets are really helpful early on, but with time we want to dose reduce them, because continuing patients on dexamethasone do come, as we've mentioned, with many other issues, including the impact on their well-being with respect to insomnia and psychological changes, but also medically on hypertension, hyperglycemia, and other toxicities. So as I try to wrap up and conclude the way we're approaching transplant ineligible patients, I would argue that as we're discussing and debating even today, that transplant remains the standard of care. But in that group, that again, I'm not being ageist, as I mentioned, age is not the parameter by which we decide transplantation, but patients with comorbidities in that 65-ish to 75-ish range, we may be doing slightly fewer transplants in light of the benefits that we can see now of non-transplant approaches. We've clearly seen that continuous therapy helps with long-term lenalidomide and maybe now even indeed with adding daratumumab as one of the options in the DRD Maya regimen. Furthermore, we've hopefully emphasized the balance of toxicity and efficacy, especially with dexamethasone. I've seen so often where even just the dose reduction dexamethasone has so impacted a patient's well-being that they've been able to remain on their regular regimen. So what is the answer? Is it VRD? Is it DRD? Well, I'm not willing to pick one over the other. My approach is to choose one of the two, that I do want a triplet combination where I take a proteasome inhibitor, an IMiD, or a monoclonal antibody, choose two of them, pair them with dexamethasone, and treat my patient. I can tell you that in general, in clinical practice, and there's going to be variability, I tend to favor using DRD in standard risk patients and VRD in higher risk patients, only because I think we have slightly better evidence for the higher risk patient receiving the proteasome inhibitor. And sometimes I can tell you I don't necessarily give the bortezomib in the way that the VRD study, the SWOG study, gave it, where actually I try to give it weekly if people tolerate it well for those first 6 months, and then drop it every other week to continue out for a year, a bit like the DVMP strategy of giving a year of bortezomib. And I found that to be something that makes it a little bit more feasible. But looking to the future, as we're hearing from others in terms of frontline therapy for eligible patients, we may be moving towards quadruplets before too long nonetheless. And so we may be using DVRD in the not so distant future. So trying to put this all together in the treatment algorithm that we're studying today, we still make a distinction between transplant eligible and ineligible patients. We generally have a triplet combination as currently being the standard of care, be it with bortezomib lendex, in some cases carfilzomib lendex, or daratumumab lendex, with or without transplant. Most patients remaining on lenalidomide maintenance, although we tend to add more to that, especially in high-risk patients. And then look at all the choices we have at first relapse, second relapse, third relapse. Well, if you think we have choice now, let me suggest that this is changing here in red, that we're going to be bringing more daratumumab to frontline therapy, that as we're debating today, there may be a benefit of CAR T-cell therapy earlier on. And all of these new options may heavily influence that first relapse. So I go back to the central premise I started with, that frontline therapy for myeloma matters. What you give your patients early on has an impact on them in the long term, giving them what I sometimes call the 1-2 punch. What we give first line therapy and second line therapy together are particularly prognostic in a patient with multiple myeloma. It's always a pleasure to serve the myeloma community here in the US, but really right across the whole world, virtually, obviously, right now. But we look forward to the day that we'll be back together and do this in person. So, and lastly, I'd like to just show you the exciting changes in myeloma that we've seen. I've listed in black what we've been doing for a long time, what red we've recently added, and then in green what we've most recently added. Obviously, you'll be hearing more today about relapse therapies and all of the new treatments, but this does have, if you will, a backfill influence on what we're doing earlier in the disease course, as we will be treating patients more effectively early on and maybe someday achieving a cure in a certain amount of patients. In purple is what I may predict is going to come very soon, where we're going to see more and more options available for patients, both in early phase disease and in later stage disease. It's always a pleasure to be a part of this wonderful meeting, and we very much appreciate your attention. I look forward in a short time to our question and answer session. Thank you so much.